Hello, everyone, and welcome. Our webinar will be beginning shortly. Hello and welcome. Our webinar will be beginning shortly. We're just going to give a couple more minutes to let everybody get into the room. Hello and welcome to today's webinar, Identifying, Understanding, and Addressing Occupational Health Inequities Through Research, presented by Michael Flynn. A few housekeeping items first. You will all be muted during the presentation. If you would like to ask a question, please enter into the online Q&A box in lieu of the chat. The online Q&A box is at the bottom or top of your screen. We'll save time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page. And if you are here today live, you will get a email with the recording tomorrow. All participants who are logged in with their registration email will receive the full live presentation in an email tomorrow with a link to the evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. Once the evaluation is complete, you'll be able to access and print your certificate. At this time, I'd like to present our presenter, Michael Flynn. Mike is an applied anthropologist with over 25 years of experience working on issues related to social inequality, both domestically and abroad. His interests include health equity, organizational culture change, translation research, and social determinants of health. He currently serves as lead social scientist with the National Institute for Occupational Safety and Health, or NIOSH, where he coordinates the Occupational Health Equity Program. He is also the project officer for a research program to better understand and improve the occupational health of immigrant workers. He has a master's in anthropology from the University of Cincinnati and is currently pursuing a PhD in anthropology from the University of Kentucky. Thanks for joining us, Mike. I'll pass it over to you.
Thanks so much, Jess, and thanks to everyone for inviting me to give this presentation. As mentioned, this is the first of a three-part series of presentations we're doing, looking at the paradigm shift to a biopsychosocial approach to occupational safety and health. Specifically, this presentation is going to be focusing on identifying, understanding, and addressing occupational health inequities through research. So occupational safety and health as a field shares some historical roots with social medicine. Social medicine was a movement that started during the Industrial Revolution that looked to explain how social and economic conditions affected the health of many of the workers who had migrated to the cities and urban areas to work in the factories during that time. Exemplary of this work would be Virchow's work on typhus among coal miners that many people are familiar with. Despite these historical roots, however, over the past 50 years, the field has evolved, occupational safety and health has evolved into a largely technical field that's guided principally by the biomedical model of medicine. Now, this model seeks to identify single proximate factors that cause an injury or an illness, and then eliminate them. And this model has been very successful over the past 50 years, and we've seen significant declines in workplace injury and illness. However, the broadening of our understanding of the relationship between work and health, exemplified in NIOSH's Total Worker Health Program, The restructuring of the world of work, sometimes called the Fourth Industrial Revolution, exemplified by NIOSH's Future of Work initiative, and increased awareness of social inequality that we've seen over the past few years, exemplified by NIOSH's Occupational Health Equity program that I coordinate, have all suggested the need to expand and complement this reductionist view of cause and effect to better account for the social, political, and economic contexts that contribute to occupational health outcomes. And you can see as I go through this presentation, there are links to both to the articles in both the images and the slides, and occasionally in the text as well, if you want to further read on any of these topics. And so this need to do a better job of accounting for the wider influences on health outcomes. We've proposed in the recent article, you can see here, the need for a paradigm shift from a biomedical model to a biopsychosocial approach to health. And basically, the biopsychosocial approach really explores the dynamic and multi-directional interactions between biological phenomenon, psychological factors, and social relationships and contexts, which constitute processes over human development over the life course. And so it's more comprehensive and tries to take into account many factors rather than trying to simply isolate a single factor and eliminating that as a cause. Now, the Occupational Health Equity program that I coordinate, the mission of the program is to reduce avoidable differences in workplace injury and illness that are closely linked with social, economic, and/or environmental disadvantage. We call them avoidable differences because in the biopsychosocial model, we tend to focus on the social aspect and trying to bring a social perspective or a biosocial perspective to occupational safety and health. And we emphasize the avoidability of these differences, of these inequitable differences, because what we're looking at is how social arrangements contribute to the inequitable distribution of illness and injury. And the very fact that they are socially constructed differences means that they can be deconstructed or changed, and therefore they're avoidable and changeable, right? But in order to do this, we really need, as I mentioned, a shift to a different paradigm that's a little more comprehensive and all-inclusive. Right? The three key areas of focus of the Occupational Health Equity Program, or this move to a biopsychosocial model of health, relate to the first is really research focused on occupational health inequities, which is going to be the main topic of the presentation today. The second key area of work is looking at inclusive research practices and integrating them across all of occupational safety and health as a field, whether the particular research project is focused on health inequities or not. And that's going to be the subject of an upcoming presentation similar to this on August the 3rd. And then finally, the third area is the connection between work and health inequities writ large, beyond those that are traditionally understood as occupational health injuries or illnesses. And that presentation will be on November the 2nd. Now, a central challenge to securing occupational health equity is that the same social structures that contribute to health inequities, such as racism, misogyny, et cetera, also operate and are reproduced by occupational health organizations. A simple way of saying this is safety and health organizations have evolved to better meet the needs of some groups and individuals more than others. Research on the technical aspects of occupational safety and health has been historically favored over that which explores the social context that circumscribe occupational health outcomes. This long-standing imbalance has led to research questions, funding decisions, data collection instruments, and scientific assumptions that are tailored to the understanding of the normative group. And this tendency fits with the larger trend of desocialization of scientific inquiry, or what Paul Farmer calls the tendency to ask only biological questions about what are in fact biosocial phenomena, right? The results here is that it limits health equity research and expertise and limits our institutional capacity to address the social factors and social context within which injuries and illnesses occur. However, despite this institutional limitation, we've seen over the past couple of years the prioritization of health equity, both within the institutions and society overall, right? This has resulted in kind of a gold rush on projects and a search for funding and incorporating health equity terms in those proposals to try and secure funds that have been, made available to address some health inequities, right? The unfortunate thing is that many of the individuals who are going after this funding may not have developed an expertise in health equity, and they simply try to apply the same research approaches they do with the normative group to address health inequities. Basically, just translating a questionnaire into Spanish and running it with immigrant workers, for example, right? The problem with this is that it assumes a level of competence that the researcher may not have if they haven't developed that competence in health equity over time, right? This can not only be, at best, these research efforts are ineffective, but they can also be counterproductive and reinforce some of the inequities that they're trying to identify and address. The other potential consequence of this is that it can displace health equity experts or adds additional competition for health equity experts for their research proposals. And you can see this has been the treatment of several recent articles that are highlighted on the side of the slide here. I think what's essential to remember when we talk about health equity research is that health equity is not just a concern for social inequities, but it's really an area of expertise that's developed over the years and through discipline and training. It contains a rich theoretical, methodological, and ethical literature. It's informed by social science, relationships with communities who have been historically underserved by occupational health and public health organizations, and praxis, just doing the work, right? And so this isn't to suggest that we aren't encouraging or inviting additional people to come, engage in occupational health equity research. Of course, we'd love to see that. We just want to encourage folks to do it responsibly and take a minute and think, do I have the expertise necessary to do this? And if not, how can I develop that? And so we'd recommend, really looking at including collaborations with subject matter experts in health equity if you haven't developed that expertise yourself, and developing relationships or relying on relationships with communities from underserved populations, if you have those, and if not, either beginning to develop those relationships or working with people who have developed those relationships. Then also generate a plan or start working on developing your own expertise. And that can start with an immediate proposal that you're collaborating with someone on, but take this as a commitment, as a long-term commitment to engaging both the topic of health equity, the science of health equity, and also the relationships in the communities that are often that you need to engage with for health equity research. And when we talk about research targeting occupational health inequities, there are three main areas of research that our program is involved with or promotes here at NIOSH and across occupational safety and health. The first is identifying which structural disadvantages contribute to increased risk for which workers, or basically, your standard epidemiology, right? So at the heart of this is the idea of social determinants of health. And while there are many social determinants of health, we've identified three kind of buckets that we think probably have the greatest impact on work-related injuries and illnesses. And so in short, what we look at here is that, how societies arrange themselves along social axes like race, ethnicity, class, gender, nativity, how they arrange, industries and organizations through things like the competitive bidding process or subcontracting processes that externalize risk and cost from large companies to smaller businesses. and how jobs are organized in society through things like different, non-standard employment arrangements or shift work or autonomy, all impact the distribution or the inequitable distribution of work-related risks and benefits across the population. Now, doing health equity related epidemiology, one of the limitations or challenges that we face is the current data systems that we have. The National Academies put out this consensus study report a few years ago. And some of the findings that they had there is that, one, in some of our data systems, we don't do necessarily a good job of collecting or including, items related to key demographic variables that could help generate a better understanding or identifying which social arrangements contribute to increased risk. Alternately, we find that some data systems do incorporate items related to demographic data, but oftentimes those items aren't completed, or the demographic data is incomplete because the people filling out the forms, often employers, won't fill out that often don't fill out that section. And so there are limitations to those data. The other thing we found is that equity research, when it does occur, is often limited to a single characteristic and is siloed. And so oftentimes, for example, I run a research program focused on immigrant occupational health among immigrant workers. And when I started out, I tended to focus specifically on the question of immigrant. What is it about being an immigrant that puts people at risk or at increased risk, right? But this is an incomplete, or this gives us an incomplete or narrow understanding and lacks this idea of intersectionality and the fact that individuals are not monolithic, but often belong to a variety of different, composite of a variety of different identities all simultaneously. A worker isn't an immigrant one day, a woman the next day, and a small business employee the following day. All of those things can overlap in their daily lives. And so our research needs to account for that complexity. In the study that was highlighted 2 slides ago, the overlapping structural vulnerabilities report that we did, we began to explore this idea of intersectionality, or what we called overlapping structural vulnerabilities, specifically by looking at Hispanic immigrants in the construction trade and how they may have overlapped as small business employees and younger workers. We knew that each of 3 of these groups faced, increased rates of occupational injury and illness. What we were interested in exploring was this intersection. And indeed, what we found, it was largely a literature review and some data analysis of existing data sets, is there is a significant overlap in that immigrants tend to be overrepresented in smaller businesses and younger than the average worker. Right? Now, the second key area that we like to look at when we're talking about research that's targeting occupational health inequalities is research that tries to explain how social arrangements materialize in the lives of workers, right? And so if the epidemiology in the first one identifies who may be at increased risk and what factors may contribute to that increased risk, this section really is more kind of your standard medical anthropology, for example, and often qualitative, but can be quantitative research as well, that tries to describe, well, what is it about being an immigrant, a woman, whatever the variables are that puts you at increased risk? How do those structural disadvantages materialize in your lived experience to create barriers to safety and health? And I think the important thing here too is, while I've been saying structural disadvantages, it's important to remember that we're not only talking about structural disadvantages, but the way we order society also confers privilege on certain people as well. And to the degree that we study this, the largest number of studies focus on disadvantage, but it's important to also realize that the study of privilege, while overlooked, needs to be done as well. But it's important to note that social disadvantage or advantage of privilege, right, is a socially constructed phenomenon, as I was saying earlier, and it's also dynamic. it changes over time and place. And so being an undocumented immigrant today is could be a very different experience than it was, let's say, 30 or 40 years ago in the United States. As the article to the side here talks about how over that time, legislation has occurred that make the consequences of being, undocumented or illegal, increases the consequences of that. And so the lived experience of that status is different than it used to be, right? It's also important to remember that these are institutional arrangements, right? Not characteristics of individuals, but they're the way we've arranged society and classified people. And the way structural disadvantages occur and privileges occur are multifaceted. It's not just one law, they can be part of laws, it's part of the media, it's part of the political discourse. All of these things interact with one another to contribute to how these disadvantages and privileges are experienced by the individual. And so the research I'm talking about here, we really try and seek to understand, how disadvantage and privilege are constructed by society, how they're experienced by workers, researchers, employers, et cetera, and how they're addressed, by the workers. It's important to remember that they find ways to address these disadvantages, in their lives as well. And documenting that's important. So one example from the research we've done is the paper we wrote on undocumented status as a social determinant of health. And as I mentioned before, illegality, in quotes, is a dynamic social construct. And really the legal consequences of being an undocumented immigrant really started ramping up about 30 or so years ago with increased legislation that we saw over time. In large part, this had to do with the fact that migration from Mexico went from being seasonal and largely male in agriculture for the harvesting season, for example, to becoming a more permanent long-term relocation of individuals, both men and women who would begin to create families here. And so what happened is that relocated the cost of social reproduction of labor. So, who paid for the raising and educating children, and who paid for, workers who may have been hurt on the job, et cetera, relocated those costs that used to be located in the families in Mexico to the United States. And so in order, as a way of reallocating, as a way of accepting those costs of social reproduction of the labor pool, an undocumented status and the consequences of that were created to begin to, eliminate eligibility, for example, to means-tested benefits here, right? And so what we see is that what's developed is really the economic centrality of the labor migrant, but their social marginality, right? And so work, versus safety, for example. And what we found in the literature is that while undocumented status is often mentioned as a reason for increased rates of occupational injury and illness, rarely is it studied. And the overarching assumption in the literature is that, well, the workers are simply afraid of deportation, and so they don't speak up. And while in our study, we found that fear of deportation was indeed an endemic concern among undocumented immigrants, right? The more immediate concern they had was the resulting economic instability that came from being an undocumented worker and not having rights or not being eligible for things like unemployment insurance, or the fact that it was increasingly harder to find a job if you did get fired, to find a replacement job, because employers were increasingly asking to see proof of work eligibility, for example. And so while all those at the root of them had undocumented status was at the root of those things, it was really the immediate concerns of economic insecurity that was, contributing to workers choosing or not to speak up at work and asking for better working conditions. And this developed one way the workers dealt with this is what we call a coping strategy of disengagement. Basically, it was a way of avoiding institutions that may be able to help workers, such as OSHA, for fear that it would create more problems than solutions. And this resulted in a degree of alienation and marginalization for these workers that exceeds the specific prescriptions of the law. And so while on the books, undocumented immigrants have the right, workers have the right to all the labor protections that a US born worker would have, in actuality, in their lived experience, that wasn't the case because, of this disengagement with some of the systems that were there and institutions that are there to help workers protect themselves and exert those rights. And so that was an example of a study that looked, at a singular kind of that siloed model of a singular and getting a deeper understanding of one particular aspect of that contributes to an increased risk for occupational injury and illness. Another way of looking at how these disadvantages can materialize in the lives of workers takes this intersectional approach. And it was a follow-up study to that overlapping structural vulnerabilities report, where we looked at how business size and immigration all both contributed to access to training in the construction industry for Hispanic immigrants. And so we knew from the report we did that Latino immigrants were overrepresented in smaller companies. And so we sent out a survey to 50 small construction firms and 215 large ones who had employed Hispanic immigrant workers. And what we found is that not only were Hispanic immigrant workers they received less required training, they received access to less tailored trainings, and less overall safety communication than Hispanic immigrant workers in larger companies. And so here we see kind of this sense of an approach towards an intersectional or multidimensional approach to health inequities for these workers, and how these arrangements, manifest themselves in the lives of workers. Now, the third general area of the occupational health research that we focus on is developing and evaluating interventions to address the barriers, the structural barriers to safety at work, and to try and help mitigate some of the health inequities that we find. So as I mentioned earlier on, the same social structures that contribute to health inequities also operate within the way our organizations work. And so when we don't, the result is that the interventions and the studies that we do are, when we don't intentionally tailor them to the needs of historically underserved groups, they tend to de facto be tailored to the needs of the normative group. And that's what the second presentation in this series of presentations will dig more in depth into. But basically what we're saying here, the result of that is that those who are most in need of preventive interventions are often the least likely to receive them. And this is known as the inverse equity hypothesis. And simultaneously, or similarly, interventions, when not tailored to specific groups or when tailored to the normative group, either consciously or inadvertently, can often aggravate inequities, as they can disproportionately help members of less disadvantaged groups, right? And so what we're talking about here is that the normative perspective, when research is done and not accounted for, becomes reified in the literature and is really a self-reinforcing feedback loop, where if we don't identify the inequities or find out how to fix them, then all of that research then influences the funding that goes towards interventions and further research down the road. And so an example of this is, a recent paper or study we did on reaching the hard to reach. It was a collaboration with the Mexican Council, its Ventanillas de Salud program, which is, and so in order to address these issues of the inequity hypothesis that I just spoke about, is really an essential component of a switch to a biosocial or biopsychosocial model of health, is the need to turn the analytical lens back on ourselves and question, so much of the health equity research that's done, when it is done, is often unidirectional and focuses specifically and almost exclusively on, the other or the group that is, considered to be at a disadvantage or has increased rates of years, suffering from health inequities. But what we realize is that, and trying to understand their reality, the problem is that if we don't question our own social position and how we approach these issues and research questions and interventions is circumscribed by social structures as well, then oftentimes our research can simply, and our efforts can simply reinforce or aggravate the inequities, as I mentioned earlier. One way of looking at this is kind of the standard nomenclature in much of the public health literature of referring to immigrant workers and other groups as being hard to reach. Now, the problem with this is, either due to, language issues or cultural issues or whatever, any number of issues that are brought up in the literature. The problem with this is it kind of puts the blame on those workers and suggests that there's something inherent in who they are or how they live that makes them difficult to reach. And I think what we do when we turn the analytical lens back on ourselves, we have to ask, well, is it really something about them that they're hard to reach? Or is it just that we as institutions haven't developed the capacity to know how to effectively work with them? Or in fact, deeming them hardly reached by us. And so by turning the analytical lens back on ourselves, we place the responsibility on us as institutions to find ways to say, okay, well, maybe it's that we just simply haven't developed the capacity to work effectively with them, right? And one evidence of this is that when you look at the Mexican Counselor Network, right, there are 52 Mexican consulates in the United States that serve over 2 million people annually. They have a health promotion program called the Ventanillas de Salud in the waiting rooms of 49 of these consulate, and 11 mobile health units that go out within, I think, a range of 150 miles of the consular office that reach out to, geographically isolated communities. And so the question is really, are they hard to, it doesn't seem like they're hard, these workers aren't hard to reach for the Mexican consulate. So it's not so much that they're hard to reach, it's that we just haven't developed the right partnerships to reach them effectively. And so I think the important thing when we're starting to reach out and do this work is to try and identify, what is the existing infrastructure that, that's there in the communities we're trying to reach, that we simply may not have access to develop partnerships with to date. And it can make it so much easier, to overcome these barriers and develop our institutional capacity to work with workers from these communities, right? The other thing that's been very beneficial of working with the consulates and, leveraging this existing infrastructure is that we know that knowledge is essential, but not enough. And so, first we wanted to use the consulates as a way of disseminating knowledge, around safety tips and how to stay safe at work to their clients. But we also realized shortly after getting involved with them that they had a whole legal office as well. And so not only could we disseminate information to workers, but we could also tell them that, hey, if you do have any questions or concerns, recognizing that occupational safety and health has both a legal and a health component to it, that here's the health information, but if you have questions or need legal consultation, you can just go right down the hall and make an appointment with the legal services there as well. And so what we did is we designed a tailored intervention and evaluated it to find out what the most effective way of disseminating occupational safety and health information through the consulates would be. So when we tailored the intervention, first, we identified the workers we were trying to reach, largely, Mexican immigrants in some key industries that they're overrepresented in, like construction, And then we did a series of iterative processes that looked in cognitive testing both in terms of the information we were giving them as well as the images we were using. And then you can see the whole process we went through to create the materials on the website and the links to the blog there. And then we also went through we went to the folks working in the Ventanillas de Salud and the Mexican consulates to try and tailor our interventions to the existing ways that they were already giving information out. I think too many times we come in and try and create the gold standard of a dissemination project, but oftentimes that doesn't jive with what our partners are doing on a routine basis. And so while we have a gold standard of an intervention, as soon as the funding runs out for that, it increases the burden on our partners to continue implementing that. So to the degree that we can, make our interventions mesh with what's already going on in the daily lives of our partners in the institutions we're collaborating with, we have an increased likelihood that those interventions will carry on after the funding for the study runs out, right? And so we developed a multifaceted field study that included 3 materials, basically brochures, videos, and posters. They were rolled out in 5 phases at 2 sites, Los Angeles and Atlanta, and a control group to try and evaluate the different dissemination formats and develop an evidence base for what is the most effective way to reach Mexican immigrant workers with occupational safety and health information through the consulates. And there's a detailed explanation of the results in the study that's, the paper that's linked here. But basically what we found is we administered, roughly, I think it was 364 exit interviews. And basically we evaluated the materials on, one, were they seen by the participants or the clients of the Ventanillas? If they were seen, did the clients, interact with them, and did they trust the information held in them? Did the materials have any impact on the attitude about safety? And did they have any impact on changing the behavioral intentions about trying to address safety concerns at work? And like I said, there are detailed comparisons of the different phases and the different materials contained in the paper, but generally we found that the Mexican consulates and the Ventanillas de Salud program in particular was a very effective way to disseminate information and reach, these hard to reach workers. And I think the other thing that's important to note about this study is that not only did we focus on generating this knowledge on these specific questions, but we framed the study as part of a larger effort at developing an ongoing institutional and sustainable relationship between NIOSH and the Occupational Health Equity Program specifically, and the Mexican Consular Network and the Mexican government in general, right? And so to the degree that we could have each of the individual projects not only answer specific research questions or specific, intervention objectives, but also contribute to this larger partnership, we found it has been proven to be very effective and really helped integrate occupational safety and health as one of the cornerstones of the Mexican government's health promotion work with their diaspora through the consulates. And so some common pitfalls or problems that can come up, or that I've seen in, intervention work around occupational health inequities, is that, much of the work tends to focus on, focus on developing accessible training methods. And I think that's very important, addressing issues of low literacy rates or, the right language or, interactive games and whatnot to teach are all very important. And unfortunately, much of the content remains focused on, increasing individual safety, the safety knowledge of individual workers and behavior modification, and less on structural changes. And part of that makes sense because structural changes are much harder to wrap your head around and create interventions around. But that's something to keep in mind, right? Sometimes the other thing is that these interventions can be guided by a limited understanding and the lived experience of the workers we're trying to reach. Basically, the second area of health equity research that I mentioned earlier, and getting the lived experience and how these structural realities manifest themselves in the lives of workers. And so one thing we have here is that, oftentimes to address my first point of that, so much of the emphasis tends to be on changing the individual safety knowledge or individual behavior modification. One attempt at addressing structural exclusion is to, include information about workers' rights in trainings. And that's good efforts, but what we know is that while knowledge around your rights is essential, it's not sufficient, right? And you really need institutional support to help exercise those rights. Another thing that's important to understand, or a potential consequence of having a limited understanding of the lived experience of, for example, immigrant workers, is the potential for unintended consequences. And so one thing we've seen with a community partner, largely run by US-born Anglos who were trying to do the right thing and promoted a Know Your Rights campaign among immigrant workers, one of their key points that they highlighted was that, if you're injured at work, be sure you go get medical attention and tell the doctor that the injury happened at work so they can file for workers' compensation. And it was a successful campaign. Unfortunately, we went a year or so later and did some interviews, which we found out about this case. Several of the workers came back to us saying, yeah, the problem was, though, that I did exactly what they told me. I told my doctor, he filed the paperwork, I won my workers' comp claim. The only problem is that I used my real name with the doctor, but I was working under a false name or a different name with my employer, and so I ended up getting fired. And so, at the heart of this is really the people who organized this campaign really didn't appreciate or understand how immigrant workers get jobs and remain employed, and the need and some of the intricacies of what it means to be an immigrant, and how that can put you at risk even when you're trying to access rights that you're entitled to. And so to eliminate the potential for unintended consequences, it's also essential, that second piece of research, of really understanding the lived experience of the individuals we're working with, or the inequities we're trying to address, right? And finally, a recent paper that I just want to highlight, did an evaluation of the discourse around culture and research on immigrant and migrant worker health. And what they found was that, in the literature, by and large, in occupational safety and health, relies on uncritical models of culture, and culture is often used to explain or reinforce inequities. Basically, what I mentioned, this idea of being hard to reach versus hardly reached, and naming, workers as hard to reach, and emphasizing that identity of them, and then kind of simultaneously washing the hands or pardoning occupational safety and health institutions, and why they aren't doing more with these groups. Well, because they're hard to reach. And so, it's important for us to remember, well, I guess it's not surprising that we have uncritical models of culture integrated in occupational safety and health, because, as I mentioned, it's evolved into a largely technical field that the social sciences are not highly prevalent in. And so, bringing that social science perspective is going to be essential. There we are. Oh, no, sorry about that. I got twisted up here. I seem to be freezing. Okay. So moving forward, I think on trainings, we need to realize that, trainings need to both recognize, address the need for structural change, but also recognize that it requires change to implement structural changes. And so both addressing, structural barriers, but also helping workers address immediate hazards and needs that they have, given the current situation is important. Treating workers as subjects of safety, not just objects of training. What I mean by this is sometimes in health equity research, or just research about health inequities, perhaps we'll say it better that way, these workers can be seen as facing significant structural barriers to safety. The problem is they may be essentialized as super exploited or almost as a way of disempowering them, saying, well, they're so disadvantaged. You know, the literature often suggests that there's nothing they can really do. And what we need to recognize is that, yes, while they do face significant, you know, structural disadvantages, they also have agency, right? And they can do things and often are doing things that researchers may not be noticing if you're unfamiliar with the, you know, with their daily lives. And so it's important to recognize not only the barriers that workers face, but also recognize examples of resilience and resistance that they implement. Now, these may not be by the book, they might not be citing an OSHA regulation and demanding a hard hat or whatever. What they might be doing is engaging in, you know, unintentional and quiet slowdowns, you know, where they're doing less work than they used to do, or finding ways around things to keeping themselves safe. And it's important, like I said, to recognize that they have agency in the ways that they're utilizing that agency to keep themselves safe and address the barriers that they're facing, right? As I mentioned also before, it's promoting the idea of institutional support to mitigate structural exclusion, right? That knowledge is essential, but not enough. You know, workers need access to institutions and help, you know, overcoming the structural barriers that many of them face to a safe, healthy working environment. And then translation research, right? We need to develop an evidence base on what are the most effective ways of moving knowledge to practice for different groups of workers that address specific health inequities. So in conclusion, you know, health equity is a central element of the larger paradigm shift to a biosocial or biopsychosocial approach within occupational safety and health as a field. Essential to this is the need for a culture shift from concern for health equity, you know, being from the standard bearers of individual concerns for health equity to really making concern for health equity an institutionalized commitment, you know. And finally, you know, when we look at health equity we need to recognize that health equity is an expertise. It's not just a good intention of wanting to do good, but there's an expertise and a vast and rich literature that's grown around this issue. And so we need to recognize, develop, and incorporate that perspective into occupational safety and health and the work that we do. We can increase our internal capacity through direct hires of bringing health equity experts in and social scientists into our organizations by training the current staff that we have and through collaborations. Another key element is going to be expanding external interest in work and health. You know, I'm thinking of non-traditional academic fields like the social sciences, like, you know, in African American studies, the gender studies, and anthropology, sociology, and other fields that have been underrepresented. And how do we bring those departments and researchers into the work we do and looking at the relationship between work and health and inequity, right? And finally, we need to look at working, how can we foreground a social and inequity perspective? And I think that's through, you know, ensuring that we have social scientists and health equity experts in leadership positions within our organizations, and also on, you know, in external, you know, roles as well, like on advisory boards and whatnot, that can help set the agenda and move and incorporate these social perspectives and inequity perspective into the work that our institutions do. And the other key, you know, final conclusion here is just that, you know, immediate actions are important. So we need to leverage this moment in time to really, you know, take advantage of the increased attention to health equity. But we need to do it in a way that can contribute to building a long-term commitment and capacity to do this work effectively and responsibly. And so with that, I just wanted to thank the Occupational Health Equity team at NIOSH, Andrea Stege, Laura Cyron, Jackie Sivan, and Pietra Cech, who helped with the article and do so much every day to help advance this agenda. And just remind you of the upcoming presentations on August 3rd and November 2nd. And with that, I think we'll open it for questions.
Yes, thank you so much, Mike. And I'm sure that everyone here will join me in saying that was absolutely amazing. One thing I miss about webinars is being able to kind of throw up some of those like emoji reactions. I was like, yes, that part. So thank you so much. And again, if anyone has any questions, if you can throw those in the Q&A box in the Zoom toolbar, it's normally the bottom or the top of your screen. And I will start asking questions now. Let's see, the first question is, strong labor unions and worker centers can help individual workers and groups of workers and can promote better laws and regulations. How do you feel about that as well?
Yeah, I would agree. And I think it's really important, the NIOSH specifically, I think has always prided itself on the tripartite, approach to this, where you get employers, researchers, and worker organizations together to address these issues. I think it's important to recognize that, while unions are an essential component to that and have been our traditional partners for the labor side, we need to start expanding that definition to include, non-traditional or these newer forms of organizing workers or worker representatives like worker centers and whatnot. So I think that's important. And I think, those are exactly the type of institutional supports that I think individual workers need access to, to really advance, and help ensure, safer working conditions.
For sure, thank you. And again, if anybody can't find the Q&A, you're more than welcome to use the chat if that is complicated. Sometimes people can't find it. There was another question earlier, and you kind of answered it already, but it's about immigration status as a social determinant of health, and kind of going through the multiple identities, as you said, that people go through. Maybe if you can just expand a little bit on your experiences with that, and maybe what, maybe if any workers have shown like how important these ideas of, I guess, interwoven personalities can be in this work.
Yeah, for sure. I think you just see it. And so, while that paper focused specifically on, what is it about being an immigrant, and particularly undocumented status, that the workers were telling us how that impacted their ability to, to address safety at work, or put them. But, as part of that, we also have written other papers that look at, the experiences of Latina immigrant workers that came out of that same study. And so looking at the overlap between being, a woman and an immigrant, often undocumented, and then also migrating, where you migrated to. Did you migrate to a part of the country that has a long-term settlement pattern of immigration, or have you come to one of the newer emerging communities? And how that either provided you access to resources and then benefited or disadvantaged, workers in different ways. And so I think what it really did is just, highlighting the complexity of it all, and then the need to just highlighted the need to really tailor the interventions and our understanding of these things. When we're trying to address these inequities and not just treat it as simply, well, they're just afraid of deportation, so what can we do about that? And that's oversimplifying what the literature says, but it's really adding a complexity to that to understand, and also seeing how, how female immigrant workers would often talk about, how they were exploited by, the male immigrant workers in their communities, and so seeing that intersectionality, and that, privilege and exclusion or oppression are rarely unique, on or off variables. It's a complex reality of simultaneously, society often simultaneously confers privilege and exploitation, and exclusion are often bundled in the same person. And really, it's trying to reflect and understand, both as researchers and workers, what are those influences on me, and where am I privileged, and where have I been excluded, to really understanding how social systems work, that I think is very important as well. I think there was a hand raised. I saw, maybe it went down.
Yeah. So if David, I think it's is it David? Yeah, if David Bowie can type your question into the chat or Q&A box, I would appreciate that. Let's see. I had just one more question, and then one more. With regard to those different identities, but also different situations, what like maybe tips would you give for somebody who's either a researcher or maybe somebody who works in occupational health equity, to be able to kind of find out what their unique areas of need are where they're at?
Oh, where they, so, you know, what particular in the geographic region they're in, you mean? Is that what you're looking at?
Yeah, exactly.
Yeah,
You have maybe somebody in California might have a different experience than
yeah.
somebody in New York, and in, you know, things like that.
I mean, to me, the baseline is collaboration, collaboration, collaboration. You know, none of us can do it all. And so the easiest, I don't know, fastest, but the easiest way I found to complement my weaknesses, you know, has been to find people either, you know, who may have more expertise or time dealing with health equity issues and the literature and the theories and whatnot that can inform what I'm doing. And really investing in relationships in the communities that these workers come from. You know, as a researcher, is getting to know them, developing those relationships over time. And much like we, you know, intentionally designed all of our research with the Mexican consulates to contribute to a long-term relationship with them that went well beyond the 4-year scope of the intervention study that we did. Similarly, we've done the same, you know, we've approached our relationships with the different immigrant communities that we've worked with that same intentionality. And oftentimes what that does is it you know, restricts your options in terms of the you know, the extent of the intervention you want to do or the length of the questionnaire you'd like to run. But at the end of the day, you know, you can't let the perfect be the enemy of the good enough, especially when the good enough can translate into a much, you know, better feeling your partners have of collaborating with you and a willingness to continue collaborating in the future. And so really it's kind of the flexibility we've gone into that in terms of both what our expectations of what needed to happen and how they could be formed by those communities. And also the willingness to be surprised. Like I said, you know, I was unaware that the consulates had a legal department. And so when we went in there and saw that they did, we're like, well, my goodness, we can totally integrate this, you know, into the information we're giving out to people. And it would be a significant help. And so really it's having that open-mindedness in the long-term, you know, proposal of how to do this and getting to know folks so you can avoid some of those unintended consequences as well. So to me, it's collaboration and long-term, you know, short-term goals with a long-term vision in mind.
Great. I know one thing that I've noticed in our own research is that sometimes you don't have to start from the ground up. There's so many community projects and programs that have the reach, they have the access, they have the language barriers under control, and there are people out there that are willing and able to help if you know, do that research. And again, like you said, take time to intentionally collaborate.
Well, and then not only in one, you get surprised on what's actually being done, and the other thing is you can't come in with a, you know, I used to work in a community-based organization. I've never heard of occupational safety and health as a field when NIOSH first approached me. And, you know, I was just like, well, whatever, if you're going to pay me to recruit people, I'll do it. But it just wasn't exciting. But then over time, as I've been working with immigrant groups and engaged in NIOSH, finding ways to sell. And I mean, one of the main reasons immigrants come to this country is for a job and to get ahead. And so the connection between work and health writ large is much easier for them to understand than the term, you know, occupational safety and health. And so just finding ways of framing and saying what we're doing in a way that's understood by them. And then they start explaining things they're already doing that have significant occupational safety and health components. They just don't recognize it or call it that, you know?
Absolutely. Health literacy is absolutely a part of health equity. And that even goes for practitioners and researchers. Sometimes we're just doing things that have different names. And speaking of which, we do have another question, also 2 questions. One, is there a CalOSHA equivalent to NIOSH's equity program or something similar?
Yeah, if there is, I'm unaware of it. I would imagine there must be. Maybe, I don't know, Jess, or some of you all out in California may have a better answer to that than I.
Yeah, I would say that there's quite a few programs, just COEH in general, Center for Occupational Environmental Health and Safety. You know, we do have a lot of these programs. We have LOHP that works, Labor Occupational Health Program. They work directly with unions and communities in California. We have that in Northern and Southern California. So please, coeh.berkeley.edu, if you want to see a little bit more, you can look through some of our programs and research that we have. And also NIOSH's website does have some of those other ERCs nationwide that actually do that research, but also in California. We have the Northern and Southern California Occupational Environmental Health Centers.
I think California has a lot of resources, like you're saying. I don't know anything specifically in CalOSHA, an office dedicated to this, but there are a lot of resources like just mentioned out there that may not be affiliated directly with CalOSHA, but certainly address these issues.
I would say California goes a lot of times above and beyond other states when it comes to making sure that some of these things are mentioned and acknowledged. I do have another question that asks, if you have the answer, what would an immigrant worker who's developed an upper respiratory symptoms from grinding manufactured stone and lost his job, how would this person obtain appropriate medical evaluation and treatment after losing that job and having that type of an occupational exposure?
Yeah, I wouldn't, it would depend a lot on the geographic region and what the resources are specifically available there to them. I think the only recommendation I would make is that not only should they consider medical treatment, but also if you're helping this individual or whatever, is also to explore what legal aid might be available through immigrant-run organizations. As in the example I mentioned earlier, we all know occupational safety and health has both a legal and a health component to it, and that's only wrinkled when you start getting into issues of immigration status and work permits and all of those things. And so I think getting someone a legal perspective of someone who's familiar with how those potential wrinkles might play out, in addition to getting them the medical evaluation and attention they need, I think should go hand in glove. When you're moving forward. If you gave me a specific location, I might be able to point you in the direction of a group or an organization there. But there are some, the first place I'd go is you may just check in with the local Mexican consulate. They usually have a list of community-based organizations that they, that you might be able to work with, or the NIOSH and some of the other national, organizations out there that deal with this stuff.
And I actually just remembered that there is there's a website through CalOSHA that does have information on groups that provide legal translation and aid just on navigating through the system. I'll find that and add it to the resources for tomorrow. But I do know that there is a part of the CalOSHA website that's dedicated to that program. I think it's an independent program that works alongside CalOSHA, but it's not a CalOSHA program specifically, but I will find that information. Okay, so I have one counter on from CalOSHA. The worker can file a complaint with OSHA, either directly, the migrant workers can use the consular protection of the consulates, and there is the email address in the chat if anybody is needing that resource. And also Juan might be able to note the program that I was speaking about that I know specifically works with migrant workers with just being like intermediary between workers who may not have legal documentation and who have like legal and medical issues at work.
Well, and even there are wrinkles with the immigrants who are, who may be on a temporary work visa, for example, and whatnot as well. It's not just the undocumented status. So there's so many different levels of immigration status and what that does and doesn't entitle you to and whatnot, that it just gets very confusing. Which is why I always recommend just, consulting with someone who really knows what they're doing.
Absolutely.
And I noticed there's something about that, people asking for the slides. I'm more than happy for you all to send those out to the attendees if you want.
Okay, great.
That would be great. And like I said, there are links in, I think all of the images are linked to the actual article that's referenced there. So.
Oh, perfect. And what we'll do is send those out tomorrow, and we can either add them to the website recording, and we'll send them out in the email tomorrow in PDF form so that you'll have access to those.
Perfect.
Let's see, I'll give just a minute for anybody if you guys have any more questions to add. Do you want to ask Mike Flynn before we hop off? And otherwise, I just want to definitely say thank you for being here. This is a really exciting series for me, for Mike, for all of us, and what we can help uncover during these 3 webinars. So the first one is today, of course. The next one will be in August, first week of August. And I believe the last one is October, first week of October.
Right. I think it's November, but anyway, we'll confirm
November.
the next presentation.
Yes, but absolutely, we will love to see you in any of our following. The first Wednesday of every month, we'll be having our occupational Health Equity series. So we will have other speakers that are really targeting different areas of occupational and environmental health justice on the first Wednesdays of every month except for July. And again, everybody will receive an email tomorrow to the email address that they registered today for this webinar with, that will have your evaluation for your certificate of completion, as well as the recording of this webinar and any available resources. So thank you again. If anybody has any questions, please email me at coehce@berkeley.edu. Thank you so much. Take care. Bye, Mike.
Thanks again for having me, and feel free to reach out. My contact information is there if you have any follow-up questions, concerns, or potential collaborations. Good luck, everyone.
Thank you.
Thank you.
Take care.